And now we want to kind of step into a discussion space. I wanted to offer a few reflections both on what Brent has said, but hopefully to tee us up for discussion. In the United States, the whole interprofessional education and collaboration movement is very big. It's a very hot topic. So people like me in a dean's role have to be speaking to it and creating the space for it to happen. And in any environment, when you're trying to make new things happen, you've got to create room for it. You have to stop other things. You can't just layer it on. You've got to create room for it. So whenever I'm trying to move this forward, we have to have discussions like this to say, why are we doing this? What are you talking about? And then getting into the how. So our hows are mainly experiments, as you heard from Brent, things that we're trying, but right now our doctors are being measured more and more on their collaborativeness, their interprofessionalness. That's how our doctors are being measured. We measure our residents and our trainees. We measure our students on this. But we also have had to change our thinking in our culture. And one of the thought exercises when we were trying to get people to think differently, I want to pose this question to you. If you were sick, would you rather be taken care of by a team of experts or an expert team? Do you get it? Yeah. Who wants to be taken care of? So again, the question, then I'll see a show of hands. Would you rather be taken care of by a team of experts or an expert team? Who would rather be taken care of by a team of experts? How many of you would like to be taken care of by an expert team? I'd rather be taken care of by an expert team.
What is the difference?
What is the difference? Can somebody offer what is the difference? Please, sir.
I think probably in a team of experts, you have people who are very skillful in their areas of jurisdiction, but may not be working together. Meanwhile, an expert team, you have all these professionals, highly trained, but working effectively towards a common goal.
Yes. And I think our system, first of all, in the United States, everyone's taken care of by a team now. Kind of the one-on-one thing is largely we think of care in the United States as a team sport. And for the most part, the history of care in the United States, it's been a team of experts. So if somebody's in the hospital, you get the expert cardiologist, you get the expert, and then the social work comes in, and it's a collection of experts, but they're not working intentionally as a team, where the sum is more than the parts. And I think most of us, when we talk with people at the University of Michigan, now they're going, yeah, I'd rather be taken care of by an expert team. But we're not so good at preparing or shaping an expert team, and that's what interprofessional education is about. So again, I'm just sharing some of the language I need to use when I'm trying to explain to my congregation, why are we doing this? What is this about? But I think especially when we have such problems in the United States with quality and with cost, I think the solution is going to be in better teams. But how we get there is an experimental space, so I'm glad you're experimenting with this. Why don't we stop right now, and just so you know, we've got a lot more slides we can talk about if you want to be spoken to. We have a lot more slides, but we'd really like to hear your perspectives, your reactions, your questions. So we'll just open it up right now. Please, Dr. Chiguli.
Thank you so much, for the presentation and beginning this discussion. I think it's in Makerere, at least at the College of Health Sciences, it's not a new concept, but when it started, we didn't really call it interprofessional education. And I think Professor Sewaka maybe has more experience with this. When in 2006, there was a curriculum review that started with the needs assessment. And there were some competences that were found to be limited in our graduates. And at the end of it all, they thought that some of this could be addressed by changing the way we trained our graduates. And also there were some things that contributed to this, like the number of faculty being low, availability of rooms, sizes of students becoming larger, and many other things. But at the end of it all, we actually adopted a form of interprofessional education, which we didn't call that at that time, but training using problem-based learning in small groups, which were interprofessional, that included medical, nursing, radiography, pharmacy, and dentistry. And it was mainly in the classroom setting. And a little evaluation has been done, but I think probably not so extensive. I don't know if maybe somebody else will talk about it having been evaluated. But I was a tutor at that time in these classes, and having been through a traditional program, I found this really exciting as a tutor, to sit among all these students from different, who are aiming at different professions together, but learning together anatomy, biochemistry, physiology, and bringing different perspectives, and also kind of neutralizing some of the misconceptions about professions. Because we would sit there and at the beginning, I remember some, especially the medical students, feeling a little bit superior because they came into the college with the best results probably. But you'd sit there and you see the contribution from all these from the other disciplines, and it was quite exciting. And I think over time, this has continued maybe in different forms, but the challenge comes to the interprofessional education and practice in the clinical settings. I think that's where the real issues to me arose. We had this classroom setting, it worked well, but when now we went to the clinical years, it was difficult to keep this momentum up, and maybe other people who are now teaching in the clinics may have additions to that. But recently, I was involved in a program that is developed modules for interprofessional education for HIV care, and I chaired a group of about 11 people to develop these modules. And I went back actually to learning because it was an interprofessional group of experts. But I was there like learning almost every day from how the nurses were training and what value they brought, the people from family medicine, and it was still an eye-opener that this interprofessional education, I think it has a lot of value at all stages, undergraduate, postgraduate, and even as trainers, as we prepare for education. But my question really goes to the clinical setting, training in the clinical setting, how that can be enhanced for the students, and how probably you have done it at Michigan, to see how that is enhanced and how it is happening.
I'll give my thoughts on that. Is that pick the places where it's working well. The learners will absorb what they see more than and they'll absorb the attitudes that people are exhibiting towards each other. So if there's a unit, when we work with nursing students, they'll say, why should I take any of this to the clinic? Because I know in the clinics where I'm doing my ward rotations right now, the doctors never listen to the nurses. So what relevance does it have to me? The nurses have no voice there. So So you start with the places where that is happening, and really focus there. And then, but it takes time and energy. You have to put, unfortunately, it doesn't work generally without a little bit of extra resource. In a lot of ways, it's a faculty development problem, right? You have to train faculty to help the learners observe and incorporate the role modeling that they're watching. But if you put it into, if you try to teach learners about IPE in a clinical setting where people really aren't listening to each other carefully, it just doesn't work. Just don't use that unit until the culture changes. Go to places where it's working. So that's my take home.
I would agree with that. And some of your comments speak to one of the things I have to do is change management, because I find that the younger people who come in are much more open to this. And then there's usually a core group of believers. There's a big group of agnostics. Then there's a big group of pessimists. And in the United States, we have a term that I hope isn't offensive to you, but it's called tribalism, where the doctors all cling to their tribe and the nurses cling to their tribe. And you take early people in the process, and they're much more open, but all of a sudden, once they get indoctrinated into the tribe. So some of the challenge I find is trying to find the leaders who are the believers, because a lot of the leaders, for example, the doctors go, I was never trained this way. This was never part of my curriculum, Joe. Are you saying I'm bad or I'm not good? Because I wasn't trained this way. So, but what we've done is exactly what Brent says. So for our curriculum, for example, we did a survey of all our clinical care settings to say, first of all, which clinical care settings have more than one cadre of learner? Nurses, pharmacists. So we did a survey, and then we did a survey of those directors to say, who thinks collaborative care is particularly good? That you've got expert teams. That whittled it down. And then where is there room for learners? Because like Uganda, our clinics and our places have lots of patients. So as soon as you kind of throw more people into the formula, it slows things down. So right now we have 3 settings where we send a lot of our early learners. So from that survey process, for example, our breast care center. So breast care for women with breast cancer has to pull together physicians, surgeons, oncologists, the radiologists, and the social worker, and the nurses, and women communicating with women. And they felt very proud of their interprofessional culture and environment. So it's a very positive learning environment. So we're picking off where it goes best, but otherwise we end up with something, again, a term we use is, in the United States, is sometimes Sunday school phenomena. Do you have this? Where you send your children to Sunday school, and during Sunday school everyone's behaving perfectly. The rest of the days of the week, people are not so, this is a Christian analogy and there are other religions, but you get my point. People know how to behave during a certain time period, but the rest of the time period they're elbowing their way in the world. So we find that creates cynicism. And so one of the things that we feel very compelled to do is trying to avoid cynicism. But I find it very important as a leader to talk like I'm talking with you today. What's the value proposition of interprofessional education? I find it very crucial to role model how I'm working and learning from the social workers I work with, from the pharmacists, from the nurses, because leaders often set the tone, and that's the strongest issue. But if people will learn from the environment that they're in, despite the formal curriculum or the assessment tools you're measuring them by. So it's trying to find where it's happening best. Other comments or thoughts or questions you have. What are some of your biggest challenges right now with interprofessional education or practice?
But can I just ask a question, put in a question? I believe that to make these things work and any other innovations, educational innovations, leadership is important. And that leaders at the institution, whether it is School of Public Health, School of Nursing, Medicine, they really need to buy in and be on board. Otherwise, the faculty will not.
Yes.
How did you do it at your place so that at that level there is a buy-in?
So usually the way change happens, at least in our place, there ends up being a champion who's trying to gather the early believers. So the early believers at our place were the 5 deans of the health science schools. So we have a dean of the medical school, the nursing school, pharmacy, dentistry, and the School of Public Health. We have 2 other deans that are part of that, kinesiology and social work, where they all said, yes, we want to do this collaborative care and practice model. They leveraged that message to our provost. And the provost created funding for a center for interprofessional education that was gathered from those constituencies. And the deans had to come in and both say, we're going to put money into this, so we care about the outcomes. But we also have to both work on what we're trying to do, but we have to remove some of the barriers. One of the barriers, for example, people had to agree on, be committed to, if there's money in it, that they have to find a way to harmonize the schedules. Because in our environment, for example, the medical student schedules are completely different from the nursing school schedules or from the pharmacy schedules. So we had to harmonize on that. So money was put in for grants. So for example, one of the grants was to say, show us where we can define some interprofessional experiments. And that's what got us starting to work with MUST in Embraer. That was a grant from our IPE center. We'd love to do IPE with Makerere, Mepi Masao, whoever we can work with in Uganda. So there was money in leadership. The message from the leadership was at the provost level, saying this is important. We're going to spend money on this, and we're going to value it. The challenge they put before us, which I think is the challenge for us all, is they said, well, we are a research institution. Come up with the evidence that this is good. Otherwise, you're just talking ideology here. You're talking about what Brent was talking about. It's a belief. But what's the evidence that interprofessional care is better? What's the evidence that an expert team is better than a team of experts? Show us how care is better. Show us how care is cheaper. So that's the journey we're on. And I think the literature is very thin on the evidence that IPE is better. A lot of us want to believe, and we want to design the experiments and work on it. But that was the other thing that we messaged to our leadership, that we're not going to go out on just a crusade, but we're going to generate the evidence that that this is a better thing. So that's the journey we're on right now. Please.
Yeah, thank you, Joseph and Brent. I think someone says that yes, it all begins and ends with the leadership, and I like the way you've responded to that question. But then also from other learning circles, we know that there are these groups referred to as the street level bureaucrats, because as you know, the deans don't usually do ward rounds. They usually don't go to the ward, they don't usually go to theater. And we are trying to bring people who have been trained differently, and it's not different from here. Even when I first heard about this, it was a bit strange, and I happened to go with Professor Chiguli in this panel of 11 experts who were being brought together, and when each one of us initially developed a module, you could see that this one was developed by a nurse, and this one was developed by a physician, and this one was developed by a family health practitioner. But subsequently, we had a number of meetings to kind of replace things, and because most of the people in the room were mature, it did take a lot of argument to make things. But I learned recently that even after that, there was a lot of back-end kind of smoothing of whatever had been done. So my question is, having got the buy-in from the deans and the high-level leaders, how do you then get this integration from the different teams who actually either do the practice or do the training, to work together and appreciate each other's contribution, so that they move this forward? Because I believe those who are on the ground are really who are going to make the real difference. If they don't agree with what leadership thinks, then it's going to be like the Sunday school that you talked about.
I can offer from the bottom up, and Joel talked from the top down. But I know that under the IPE Center, there was at least one faculty member from each school who was funded. And so from my end, I started working with our supported faculty member of the IPE Center, who is an emergency room physician. So he became my liaison for anything that I was involved with around IPE. We wanted to build a new program, we wanted to introduce it to this place. I had a touchstone from somebody who was in the trenches. I mean, he's an emergency room physician who is great, but he got it. And so I think that one little piece of providing some support for a faculty member in each school probably is a critical part of that. My final note on this, from the medical school point of view, this is Dr. Joe House. So Dr. House says to me, it's hard to get our students in at the pre-clerkship level, but our students do participate. They were medical students in that large Chrysler. But it's a harder throw into the clinical years, especially the clerkships or the post-clinical years. But for me, to have him working on it, he's looking for the places where this can happen. And as they open up in the medical curriculum, we've at least got somebody there who can push the ball down the field.
Yeah, it's interesting that you mentioned emergency medicine. So 30 years ago when I was a resident, emergency medicine was just emerging as a discipline. So in the United States, at the time, it was considered kind of just a triage room. It's not really a profession. People would go and get people directed in the right place. So now it's a profession. It's a very respected profession. And it's a place where obviously people have to work together. You know, somebody comes in, you get the orthopedic surgeon or the dermatologist, so it's a very strong environment. So they're again in that group of early believers. Again, I think we're segmenting the conversation into care and practice. When it comes to practice, we've got our education and practice. When it comes to education, we've got it built into space in our curriculum. And then we use the feedback from the students to leverage change. So first of all, deans, you're putting money into this. Are you getting good value? The students like it or they don't. But it's not just about likes, but are they better for it? And so trying to leverage that as something, and I have to tell you, some of our first IPE experiences weren't that good. We kind of got to Brent's explanation to Dr. Chiguli that now we're sending places where care is best. Otherwise, we ended up having people coming in and preaching about their tribe. And this is what's wrong with you doctors, or this is why we don't get what we need from you other health professionals. So we had a lot of, I think, failed experiments, but it was suddenly, so now we've kind of hit a point where what we're doing the students like. Brent showed you that picture of our big basketball arena, because we need a big room to get everybody in, coming and finding, and that's an energizing moment. So we're trying to kind of cone down on the moments where people feel energized in part of it, and they want to believe, and now how can we leverage up the experiments from there in terms of what people are doing. The other thing that we're trying to challenge people with is to try and actually turn this into scholarship. How can people start to write the papers and start to publish on the things where, what are they doing in terms of curriculum or their assessment tools, or what do patients think when they see a doctor and a nurse and a social worker all talking about them together? What do the families think? There's a lot of papers to be written that could lead to the evidence base of why this is better. So it's kind of an easy, so one of the things we're trying to do is elevate the importance of that as a research space. Sometimes in big research institutions, there's only certain kinds of research that is treasured. You know, for a time at the leading public research institute, it was, if you're not doing molecular biology, you're a different species of researcher. But now we have much more, I think, a holistic approach to scholarship when you're doing population-based health and other things. You know, the NIH is still doing a certain kind of funding, but for our promotion and value and for students doing scholarship, these projects are a bit more accessible than trying to get their molecular biology techniques down. So, so we've created an excitement and a movement around that. That's also been helpful.
Here's one thought related to the research agenda here. I'm really interested in someone asking the question, who's on the team? So the dominance of this model kind of presumes a team, right? And so to have a team, all of this pedagogy presumes that there is a set number of team members, that those team members know who they are, they know they're on the team, and they know who else is on the team. But so often in real clinical practice, those presuppositions are not met, and it's easy to see that if you take the patient's point of view. You ask, who would the patient say is on their team? Because that really defines who's on the team. At Complex Care, we define a member of the healthcare team as any person whose decisions or behaviors directly affect the health of the patient. So of course that means the first person on that team is the patient. But the second set of people are oftentimes not among the classic health profession teams. They may be caregivers, family members. They're on the team because their decisions and behaviors directly affect the health of that patient. That has implications for how we think about teaching and care. And then finally, other members of the healthcare team that may be in different locations or at different times interacting with that patient. They may be community health members, they may be community health workers, they may be, but that are not at the table when we have a interdisciplinary team meeting. So I think there's scholarship to be done around that by asking what presumptions and what actualities are at play when we ask of the healthcare team, who's on the team?
Is it not possible that you have somebody as a member of the team If you ask the patient, who are the people on the team? So it's answering the question of who's on the team. The patient may not be aware of somebody sitting in the lab and looking at a biopsy whose report is going to come and affect the health of the patient.
It's true. Patients don't always know who all's decisions are influencing their health care.
Right.
You have to.
And yet the behavior of that person out there matters so much to the outcome.
Yeah, that's our job, to figure that out. I remember a day I was talking with my complex care team about who's on this patient's team, and it was a person who was living in supportive housing, had a serious substance use disorder problem. And every time we got something in place, they had another meeting with their drug dealer, and everything went off rail. And I said, so, okay, there's a person, the drug dealer, whose behavior and decisions have a direct influence on our patient's health. Huh. What do we think about that, and how do we think about it? So I put it out there and just say, so that person is actually on their healthcare team. I mean, not in a way that anybody would want, and not in a productive way, but it did help open up our eyes, same way for the patients, to help. Now, in the case of a biopsy, that's a decision that's made once. And so I wonder if the healthcare team isn't as much who's on, maybe I left out a piece of the definition, this is a question, whose ongoing decisions and behaviors make a difference in the health of a patient. I'm not sure about that, Nelson. I'm not.
Yeah, I think part of that piece
Yeah.
that it was in a different direction.
Yeah, but Prof, the pathologist, depending on what result they give you, maybe their report came in once, but sometimes they give you a diagnosis that kind of takes you from one direction to another, depending on how they have interpreted their findings. And that can play whether you just needed some one-off treatment or you need lifelong chemotherapy or radiotherapy. I'm just,
Huge implication.
yeah, so it might be a one-off, but it has lifelong implications.
Yeah, it's interesting because you remind me of Professor Zeeland-Kampo. Our pathologists are now marketing directly to our patients to say, you want to understand your diagnosis better, we're happy to talk with you. Which is an odd thing for me. I see it as a call. We want to be seen by the patients and part of the team. But it's odd. I'm a gastroenterologist. So I do GI procedures and I'll diagnose cancer or inflammatory bowel disease or something like that. So I feel like it's my job to explain to the patient what that means. Whereas a pathologist, but they are reaching out to the patient saying, do you have questions about your diagnosis? I think the thing that I took away from your question, Prof, is that I think a lot of times we assume the patients are people like us, but at least in the United States, most of the people have highly variable health literacy. You know, some people can't read, and they just say, I'm going to the University of Michigan to be cared for. I'm going to Makerere to be cared for. They don't know the difference between a medical student and somebody who's more sophisticated. So it's how do we kind of pitch things to people like us versus most of the people out there who don't know. They would, I think most of them say, I want to be taken care of by a team of experts. I just want to have experts. I think this conversation would need some explanation for most people.
So, thank you for the presentation. My question is on the way you're implementing the IPE. I've seen that you get the students and put them in the hall and it's an energizing moment. But I did see how you are involving the doctors who are working, the lecturers who are teaching the students, who run around with them in the different units. I'm not sure whether you're using a bottom-up or a top-down approach to institutionalize the IPE.
So maybe if I could reframe, what I think might be the question is, how do we get the teachers to do what needs to be done?
Yes. I didn't see them in your presentation.
Yeah, and as an education dean, I wrestle with this all the time because people are paid for their clinical care. They're measured by their research, and the teaching is just an expectation. You know, they're not necessarily measured or rewarded or paid on their teaching. So one of my main things I'm always trying to do is figure out how do we value people who teach and educate. How do we? Some of the times we message it and we say how we're trying to look at people differently for promotion. We have some monies that we can create effort for. But when we're starting the movement, a lot of times we're speaking to people's hearts who really believe in this and are going to find the extra time to do it because they think it's so important. So it's kind of calling on a bottom up and trying to remove the barriers from people doing what they want to do and believe when what they're being measured by is being imposed by them. One of the other things that we also do in our culture is we try and create awards or celebrate who's the team of the month. If you look at our white coats, we have little badges sometimes or symbols. It's kind of like a soldier. They got their ribbons. So some of our white coats, you see these badges. They've been recognized by being a certain kind of teacher or provider, things like that. So that at least people take pride in that. Patients have thought I was great and went out of their way to write a letter about me. That gets a little badge. And people start to see it in the culture. So there are little things like this. But do you have other things that you can think of that speak to a penetrating question?
There are some places where teachers have the heart. There's some places where people do this naturally and they're teaching it by just what they're doing and they don't even know it. And then there are and faculty development is an ongoing challenge for medical education for all the reasons that Joe just mentioned.
Yeah. You at the beginning set yourself a time period. We must be into this for at least pick a number. The reason I ask that is if you are doing that for 1 year, or let's do this for 1 year, in 1 year you may not be able to show the difference. You may not be able to show the evidence that you mentioned, and so forth. And from your story, you are in, you are out, you are frustrated, you are back, and so it looks to me, unless there's a commitment from the beginning that let's have a number of years on this, may not be that effective to get started.
All I know about that is that, and I'm going to turn it over to Joe, my informal conversations with the IPE Center, I think there is a set of goals, timelines, and metrics that they aspire to. But I'm not on the inside track of that. But from my point of view as an educator, the momentum across all the schools for IPE forward rides with the IPE Center because they're the voice that has this constant kind of feeding the flames. And without them, I think a lot of momentum would be lost. But as far as their specific metrics and what those are, I don't have a well-refined view of that, Joe.
Yeah, and I'll maybe say a little bit about maybe our culture, which is it's a research institution. So they encourage experiments with a realization that 90% of experiments fail, but hopefully inform the next experiment that'll be better. So that's we do all kinds of research. A lot of it doesn't work out, but hopefully people say, my experiment to treat cancer didn't work. We shouldn't be treating cancer. No, that experiment didn't work. So the experimental culture is very strong at the University of Michigan, but it's got to be purposeful. How are you getting better? I say that because I was at another place you may have heard of, Mayo Clinic. So Mayo Clinic, I was there for 10 years. That had a very top-down, they set the culture. But it's a very much of an experimental culture. To Brent's point, they started off with the center and with people who wanted to experiment in this space. And they said, you've got 5 years. So that was the timeline, and then we'll revisit it and renew it. So we just came up for the 5-year renewal that just got renewed.
For how long?
It's another 5 years. So in our setting, there's always a couple of things. A, is it renewed? And B, what's the funding level? It's fine to say you're renewed, go find your own money elsewhere, versus we're giving you money. So it was renewed, they're giving money. It's not quite as much as it was before, so they're pushing people. But it's very important for us at a university to sundown projects or say, that's the end of that. So people believe that we're still struggling with the experiments. When we're thinking about educational interventions, we follow the Kirkpatrick framework of outcomes. Are you familiar with that? Anyone know the Kirkpatrick? This is useful for education outcomes people when you're trying to say, what's your evidence? So level 1 is, did people like it? Satisfaction. All right. So did the students like it? Do people like it? All right. That's kind of a low bar. Level 2, are they smarter? All right. Do they know something now that they didn't know before? All right. That's level 2. Sometimes people do pre-test, post-test, things like that. Level 3 is, are they doing something different because of that smartness? They like it, they know something more, and they're doing something different. All right? They're performing, they're acting differently because they're smarter. And then level 4 is the holy grail. Are patients better because of how people are acting, because of what they know, because they liked it? So we're always trying to work our way up the food chain. All right, and that's the challenge of interprofessional education right now. So we can show, we're trying to find the space that, yeah, we like this. And trying to show, as Dr. Chiguli pulled up, all right, are people competent, at least in their knowledge, but are they acting differently? How do we know that? So it's an incredible arena for scholarship. Either any one of those things, you can figure out how to do a survey or a perspective or something like that to be able to generate the evidence base. But we're working on that, and we have papers and things that come out. So people still want to believe. They keep reinvesting in it, but you're right. I don't think, if you're trying to message from leadership and you say, this is really, really important, I want you to do it, and you've got a year, that's a cynical message.
And I want to add to this one thing, that is one thing that has helped leverage the research and scholarship around this is something that the IPE Center did, which may be translatable. For years and years, there was an annual medical education day where all the medical education scholars would pool their work and present them to each other. It was a half day or a day-long seminar. In recent years, that day has become called the Health Professions Education Day, HPE Day, It's run and operated by the IPE Center, at least as far as I know, and the entire focus of that is interprofessional education. So it's an entire day where all of education has basically become synonymous with health professions, interprofessional education. And there's just an explosion of posters and conversations and presentations and papers in the works that comes up every year at that annual venue, and it demonstrates value to that form of scholarship. Ronnie? Yep.
Thank you for the presentation. I think like Professor Sionka had said earlier regarding the leaders. So if we get to the clinical work, the clinical teaching, realize that, for example, like in psychiatry, normally the psychiatrists will sit with the nurses, and then together with you, the students, and then together with the patient. They discuss, and then before discharge, they will have an input of maybe what does the students think, what does the nurse think, who has been with this patient for so long, before even considering anyone's decision like discharge. But you realize that in some disciplines, you might go to a ward round, and doctors are starting off, and then there is no nurse, and it's only like a team of doctors which is starting off. And we had an experience like in my undergraduate, Dr. Gapoya at 3C. You wouldn't start a ward round without a nurse, without a pharmacist, without intern doctor. It had to be a team. So you find that it was always interesting when you begin with the ward round. So if our leaders, the seniors, if before they start a ward round, they want a pharmacist, they want a nurse, they want all the other people who should be what? The team, it normally works out so well when the leader is driving the whole system. Yes. So if it is encouraging the various disciplines, whether it's cardiology, neurology, gastroenterology, like Prof. Kajimu tries it out in the GI ward. Wouldn't love to find a resident who doesn't know the name of the nurse they're working with. You can spend there 1 hour to show you the importance of knowing whom you're working with on your unit. And you realize that it helps. Because at times, in case of emergency, you can easily call them, but at times you find you're working, you don't know whom you're working with, you've been there the whole week. They're asking, who is your nurse you're working with for this week? You don't know the name. So
something I'll add to that, that's all very, very true. And educationally, something that helps enormously is after one of those sessions is to debrief the learners as to what they observed, what they heard going on. And that's the venue to help learners know how to listen and how to be listened to. If you get learners from multiple disciplines especially, oftentimes you'll hear us say, well, the doctor was, a social work student will say, the doctor was talking, but I didn't get what they meant when they said the patient has CHF and an EF, blah, blah, blah. So then you turn to the medical students and say, how hard, wouldn't it have been easy for that doctor to have used more plain English or translated the medical terminologies, all the acronyms that doctors use? So there's a skill in both listening and being listened to that requires some thought, and it really augments the power of the learner in an environment like that.
One of the things I do when I hear, first, it's an excellent observation, and you find that in our environment a lot as well. So one of the things when I'm trying to leverage change around issues like that, it's trying to measure that, trying to turn it from an anecdote into what percent of people are doing that. Is it 10%? Is it 30%? Is it 80%? But all of a sudden to quantify it and to elevate it, and then to ask people, which team would you like to learn in? The hit and run, let's go, or the team? Which kind of team would you like to have your mother cared for by? And it's kind of starting to define it and shine the light on it explicitly. So,
Joe, I'll take you there and ask, so as you quantify, just looking at the other side, does it all matter also to qualify? And here I'm saying, as we do some evaluations, sometimes there are lots of quantitative, like this proportion, but does it also help in the same setting to try and find out what maybe the people who are not doing it think about it, and maybe why they are not doing it, because sometimes people want to do a lot of that, but you find that there are so many limitations that maybe you want to do a ward round with a nurse, but the nurse is covering a span of so many units within the ward, and that getting them to do a ward round and a teaching round with you is next to impossible. So if you waited for that, maybe you couldn't. But that could be used for advocacy, maybe subsequently. I'm just trying to bring out the point that also understanding the why might be very helpful, especially at the beginning as we try to build this.
Such a good point, Fred. I wonder if I could use this as an opportunity to put one of my colleagues on the spot, Dr. Cheryl Moyer. Dr. Moyer, first of all, she's a public health professional working within the medical school. So she's interprofessional, but she's also, she's gotten her tenure largely around qualitative research methodologies. Not necessarily IP, but having to do with maternal and child health. But any reflections, Cheryl, as you listen to this conversation with our colleagues, but also you think the role of taking a qualitative approach to understand what's going on interprofessionally among the different members of the team?
Yeah, so first of all, thank you for the introduction. I thank you all for being here. It's always lovely to hear perspectives from our colleagues who are in the field here. I think the qualitative approaches can help us understand what those numbers mean. And I would imagine, for example, asking colleagues who may be non-physicians, who have never had anybody ask their name in the team, and talking to those team members and understanding how they are perceived, and then how they perceive a team in which everyone does actually know each other's name, and in which there is time taken to make sure that the team is functional, and how that can qualitatively, how that feeds into their sense of loyalty to the team. And there's other issues that would be difficult to put a number on. How do you quantify loyalty? How do you quantify, respect? How do you quantify some of these issues? I think are very difficult to quantify. So the challenge is, while numbers can be very convincing, and we all would like to see numbers that, patients, X percent of patients say Y, or X percent of teams create Y percent improvement. That's ideal. Absent that, qualitative research can be a very compelling way to frame some of these issues, because all it takes is a really poignant quote from a family member or from different members of a team that speaks to the issue, that can really drive it home for the lay people who aren't in this space all the time. And sometimes those lay people are the ones with the money, who may be able to foster future projects, or maybe the decision makers. And so I'm a huge believer in the qualitative process. So for those of you who have not thought about qualitative research, you have beautiful colleagues in the building next door in the School of Public Health who do fabulous qualitative research. And I would encourage you to reach out to them, because I think it's a huge area of opportunity.
There's one thing that your comments make me think of, Cheryl. So, like you, we have big movements. Interprofessional education is one of them. Another one, I wonder if this is talked about openly here, burnout, health profession burnout, resilience. The whole team is burned out, all right? And people are weary, and care isn't as good when people are burned out. And at least a lot of the qualitative research in our environment has found out it isn't that the work is too hard, it's just people can't do what they want to do. So they're losing the meaning from their work. And your question made me think of that, Fred, when there may be a nurse who knows very much she wants to be part of the team, she was invited to be part of the team, invited to be part of rounding, but there's somebody who needs a form filled out right now, and they can't be part of that because there's some other thing that's calling them. So there are too many things for somebody to do that they can't do the thing that they feel most passionate about or gives them the most meaning. So that's what we're finding in our environment. It's not that people are working too many hours, they are, but lots of people work hard, but they feel so good about what they're doing. It's just their meaning is diluted by a bunch of stuff that is not connected to their heart and their feeling of purpose, and it burns them out. So that's another thing that we're trying to think about and take a interprofessional approach to burnout and resilience, because it's affecting everyone right now. A lot of meaninglessness seems to have crept into their day's work.
Yeah, thank you very much. Looks like time is not on our side. But I think we've had great opportunity to interact and learn. You know, recently, as I mentioned, I'm quite new to this way of doing things, but we've just been coordinating a training for our postgraduates, and I coordinate the HIV course within the department, and most of the time we do it either a student presents and then the facilitator enables further learning. And when we did it this way, many of the students have come back to us and say, why don't you do it like this all the time? Because this is easy to learn. It is,
Great.
Leveled, and we are learning so much from. But as you said, you know, it is quite labor intensive. But we are thinking about this, how do we make it better? So, yeah, thank you very much for giving us some history, and I'd like Professor Sewanga to close this discussion.
Well, he's putting me on the spot. First of all, let me say, express profuse thanks to you and your team for visiting us today and tomorrow. IPE, I find it very exciting, and as Elsa mentioned, we started doing something like that, but though at that time we didn't elaborate as IPE. And of course, related to that is the thinking that we need an environment in the clinic or on the wards or in the community that actually promotes interprofessional education practice. And so the number of challenges that we have to deal with if this is going to progress in the way that we had envisioned. But also, and from this particular discussion today, the issue of turning IPE into scholarship, I think there's a missed opportunity there, and we should try and discuss more to see how to get seriously into that space, because it may make it even more exciting for the teachers themselves, but also the students as well when we do that. So, of course, there are resources required for that. But if we don't think about it, we can't get there. So we better start looking at it and see how we do it. And not just at Makerere, but with the partner institutions that are participating with us on this journey. So, briefly, thank you very much. And personally, I've enjoyed it. He has had me several times. And I'm very excited about IPE, and I'm always looking for who are those people that are as excited as myself.
We're in the group.
We can do it.
Yeah, thank you.
Thank you very much.
Thank you all.